Hello, we've got another episode of the Talking Trisomy podcast brought to you by Soft, where we talk all things trisomy. That's all we're here for. And so today is really exciting because I'm joined by my co-host, Dr. John Carey. Thanks again for joining with me. I'm so excited that we get a chance to talk to two of the leading experts. We have Natasha Henner. It just is outstanding. Let me give you a little bio. So I'm going to do a little reading because she is this cool that she's doing a lot of work for trisomy kids. And so Natasha, Dr. Henner, will go with the professional sound. She's a neonatologist and a pediatric palliative care physician at Lurie Children Hospital. And if you can look in the background, that is downtown Chicago in her back window. So yes, Lurie's is in downtown Chicago. And she's part of the Northwestern as well. So a lot of cool stuff going there with that hospital and that university. One of the big things is that she co-leads the perinatal palliative care program through the Chicago Institute of Fetal Health. So there's some projects we're going to talk about that she's a part of. You are the division head of the pediatric palliative care at that hospital, at the Lurie Children's. And you do quite a bit. It says here you split time. So when you're at the hospital, you are just not doing one thing. And you'll be able to correct me on some of these pronunciations, but between the neonatology, the perinatal, and the pediatric palliative care, you're covering all sorts around. So I imagine your schedule is quite different day to day. So again, thank you for joining with us. And you've been working alongside our other guest, Grace Knowles, and you've started and founded the Lurie Trisomy Care Collaborative, and you started that in 2023. So quite the accomplishment. We're excited about an announcement that you two have. So let me get to Grace real quick, and then I'll turn it over to you guys to kind of please toot your own horn. You are doing such fabulous work there in Chicago and making a huge difference. But Grace, a perinatal palliative care nurse practitioner there at the same hospital at Lurie's, and you are the co-leader with Natasha as part of the Trisomy Care Collaborative that you guys have created there at that hospital. I'm just so excited for this groundbreaking work. It really is. There's a handful of institutions that are looking at trisomy 18, 13, and other related conditions with this focus. But I really appreciate you two. I appreciate your hospital and all of the attention they're giving you. So I couldn't, if we could have a round of applause, we would. I know a lot of families have told me great things. I was just talking to a gal in the Chicago area, and her husband are just in love with your hospital. So thank you for just putting an attention on these conditions. So with that said, I hope I did you justice. Everyone listening, these two are amazing, and you'll get to know them a little better throughout this conversation. But thank you for all the work you're doing, and let's get started. Now, Dr. Carey, those that are watching for the first time, John, you have done such amazing work. You're out of Primary Children's Hospital for all these years, for many years. And we're just grateful that you're here with us to carry on this conversation. So thank you again for being here as my co-host.
Welcome.
With that said, there is a massive project. John, do you want to lead us off with a question for these two, or what's on your mind?
Well, I think we'll probably get into this, but Grace and Natasha, I'm very interested in, and I think I know part of the answer, but I'm very just interested in how it is that you develop this focus on trisomy 13 and 18. That is, why not, we'll pick some other not so common disorders. Why not have the same effort, let's say, on spina bifida, which maybe you already have, or on Down syndrome, or on skeletal dysplasias, or on new syndromes identified by genomics, or something like that. What made the focus on these two conditions, or what made that come about?
Yeah, thank you, John. And so thank you, first of all, John and Nick, for hosting us today and for giving us the platform to talk about the work at Lurie. We're very grateful for this opportunity because we feel very strongly about this work. And I think your question is a perfect setup to get us started. I mean, I would say because there's already a focus on other complex conditions of the ones you mentioned, whether it's spina bifida, single ventricle, or skeletal dysplasias, there wasn't a focus on this condition at Lurie and probably in other hospitals. And I feel like we both had certain clinical experiences that highlighted a need for truly more of a multidisciplinary care approach to this condition, similar to the other ones you named, because it is just as complicated, just as rare, just as unique. And those parents struggle in just the same ways, finding a team, not just a person, but a team who really knows about the condition, who can guide them from the time of diagnosis through all of the potential care options. And we just, I think, saw that as a gap. I mean, I can share maybe my kind of personal, like, kind of this moment when I was like, oh, wow, this is really a need. I mean, as Nick has sort of mentioned when he was getting us started, I practice in various parts. So I'm both kind of a fetal person, a NICU person, and a pediatric person. And, it's great and hard to wear all of those hats at times. And I thought a lot about trisomy 13 and 18 in our fetal counseling as a perinatal palliatist, where the focus is on supporting decision making, but also talking about the actual condition and the medicine and the challenges of the ICU. But I remember being in the NICU on service as a neonatologist, probably 4 or 5 years ago, taking care of a baby with prenatally diagnosed trisomy 18. It was a very late referral to our fetal system. That mom was 34 weeks pregnant by the time we met her. There wasn't a lot of time for decision making. There wasn't a lot of time to really kind of understand who these people were. But it was very clear they want an attempt. They heard many negative things about the condition. They were struggling to put it all together when we first met in the fetal consult. And all we could say is, we're here to try, let's try. And then fast forward 4 months when I'm now in the NICU taking care of this baby. This is prior to the Trisomy Care Collaborative, hearing sign up from my partners who say, this kid was now intubated for 4 months, multiple failed attempts at extubation, has a large VSD, has not yet had a cardiac cath, has all this GI dysfunction, and we just need to keep talking to parents about goals of care. And I remember thinking, goals of care? Like, we know their goals of care. It's to keep trying. They keep telling us that every time she fails an extubation attempt to reintubate her. That seems pretty clear. And I just started asking very specific questions like, did she have an airway evaluation? Do we know anything about what the cardiologists really think if we put them together with the ENT doctors and with the surgeons? And everyone's like, I don't, we keep trying to have meetings, but I realized the focus of those meetings is not on medical care. It's on the social care. And so I remember talking to the ENT partners saying, what do you think about taking this kid to the operating room for an airway evaluation? They said, I mean, sure. No one asked before, or she was always too sick. And we realized she has major airway challenges. She's probably never going to extubate. We need to plan for a tracheostomy, which then feeds into the conversation about cardiac repair and what to do about that. But while those people were in the rooms together at some point, it was never really that sort of cohesive, I would say, because every team was waiting for the other team to make some decision. And that's when Grace and I talked and said, palliative care has a role in the care of these kids, but there really needs to be a medical management group. Like, we just need to bring people together who have a shared medical goal, which is to make these kids better if we can. And so we sought out partners from each medical and surgical specialty to say, are you interested in this patient population? Do you also see this as a gap? And not to our great surprise, because there's lots of people here who love this work, every medical and surgical team said, yeah, we actually have a champion who really wants to do this. And so our first effort was to come together. This is now probably 2-3 years ago, from each specialty and say, what do you see as a problem? What do you see as a logistical gap? Not the philosophical gap, not the like, should we do this, should we not? Like, let's commit to doing it, whatever it is. How do we do it? What's the structure of it? Who communicates when? And we started putting some processes in place that then later became the Trisomy Care Collaborative. And then from that stemmed conversations about, more, again, practical things like how do we screen, whether it's bone disease or seizures or cancer risk? How do we share this information with parents? Which then led to developing this family-facing brochure around this entire collaborative and what we offer. Like, it was really a multidisciplinary project that's identified based on the logistical gap. So I hope that kind of maybe is the start of the conversation.
Oh, fabulous discussion. I'm wondering along the way, Natasha or Grace, both of you, you did allude to the idea of someone perhaps saying, why are we doing this? Do you think, in your experience as a neonatologist, then also going through palliative care, do you think there is some kind of, and it's called by SOFT, the narrative, do you think there is some, we'll call it bias, worldview, attitude about treating these two conditions differently than the ones we talked about, or others that we talked about? Do you think there is in our world a different view about these two special conditions?
I think so. And I also think it's changing. I think it's not that dissimilar view of, for example, saying babies at 22 weeks cannot possibly survive 10 years ago. And now we know they can in certain centers, maybe not in all. And I think that's a very similar narrative about this disease that for decades, right? For decades, people from medical school, from nursing school, from genetic counseling courses have been taught certain sets of facts. And back then, those facts were true. And now we realize that, as with anything else, once you start doing something, perhaps the outcomes can be different, not for everybody, but for some. And so the facts shift, but there is a delay in the shift of the real facts, which are there are some kids who can live with these conditions much longer than we expected, with maybe even slightly different set of skills than we expected. These are facts. But to catch up to from practice to that, it just takes time. So I believe in 10 years, I hope, everyone will know these facts, and not just know, but really believe them to be true. But it's still taking a minute. Yeah. And so if you receive your care here at Lurie, we say certain facts. But if you receive care at a smaller community hospital in the state of Illinois, you might still be hearing different facts about this condition. But as you all know, because you live in this world, parents get online and they see yet another set of facts. And it immediately creates tension and mistrust and anger around what has been said. And it's really hard to believe that a healthcare system is on your side when you hear such different narratives from different places. So our kind of attempt and hope is to bring it all together in a hopefully somewhat balanced view to support both the new facts and some differences in feelings and opinions about those facts, because that you cannot really standardize. But I do think there is a little bit of a gap of how we think about this disease. And I think there's a lot of also narratives around not just the truthfulness of what the data suggests, but how people feel about it because of the long-term outcomes of some of these babies.
Yeah, go ahead, Grace.
I would just say I'd also add that I've seen over the time that we've created this collaborative and we are doing this work that we also influence the people around us, because they too see, maybe this wasn't what we thought, or maybe there is more that's possible, or maybe this wasn't as hard or as challenging as maybe we had in our minds, or maybe it was, but it just gave you a different feeling when you witnessed this very thoughtful way to shepherd our our patients through the system and help them thrive to their greatest potential. It
I mean,
influences others. Yeah.
and being treated no differently than any other child with a complex or potentially life-limiting or potentially developmental disability condition, right? I mean,
Right.
that's the point somehow, and both of you articulated it in ways that I couldn't second more enthusiastically, but just, um, I was getting to the point that there is, the point we brought up, that I think there is something different about the way we grew up. At least I grew up, probably Natasha some years later grew up different about trisomy 18 that you already said, Natasha, that's clearly changing, clearly evolving. And I couldn't agree more, underscore that what determines it is the data.
Mhm.
That is, we had some before 2016, but in 2016 and 2017, cardiac surgery studies all rolled out suddenly, and you said it beautifully, suddenly we have the data.
Right. No, I agree with that, Jen. And, we are truly standing on the shoulders of giants, right? The people who have decided to collect the data, went through the work, probably had lots of challenges publishing it because it was back in the day a pretty controversial thing to talk about, to openly say, there are 5-year-olds with this condition who, by the definition of their parents, are thriving. And you may have a different definition of thriving as a healthcare professional, but we can no longer ignore that there's different narratives of what thriving looks like. And no, not all of those kids died in the delivery room. And no, not all of them have a tracheostomy. Like, that must have been hard work to publish. And I'm sure hard work to present at conferences. And so we are here 20 years later saying, listen to that. That wasn't a fluke. There are massive trends now. And, those data change the outcomes in a way, right? I think it's a circular pathway. Like, so now you read it and now you're like, oh, maybe putting in a G tube is not a big deal at all. And so there's more kids with G tubes who can now get better nutrition, who can get better bone health, who can grow, who can qualify for a VSD repair. Like, it sort of perpetuates that. But again, I can't say that enough. I think so much work has been done to lead to this moment. And now the work is maybe slightly different. It's not to keep convincing people there are survivors with this disease. It's to keep convincing people that those narratives continue to matter and the systems need to continue to change. And there's a lot of flexibility we can all start to exercise around that, and continue to add a lot of nuance to that, because some of those kids do have tremendous challenges and some parents do have doubts. And it's okay to now, again, not just be so binary. It's not all in or all out. There is this middle now that I think is maybe the new terrain in this disease.
Thank you again. And you said something that I hadn't quite thought of in the way you said it, but yet I think it's accurate. The people who did lead the way, we can go back 2006, Dr. Tomika Kosho in Nagano Children's in Japan. He did get some pushback from other people. Maybe he coerced the 24 families is what he told me, to actually go along with the idea of full intensive care without cardiac surgery, because he didn't have a cardiac surgeon in Nagano Children's in 2003-4. He did submit that paper to Pediatrics. It was not accepted, and it was accepted along with an editorial I wrote in the American Journal of Medical Genetics in 2006. So a little bit. But one other story that relates to soft, Nick knows partly. You may be familiar with the paper that I'm the co-author with Bonnie Beatty, a genetic counselor at University of Utah Primary Children's, who in 1994 had a paper, again in the American Journal of Pediatrics, American Journal of Medical Genetics. It was rejected by Pediatrics. We submitted it there first, even though it had been solicited by one of the editors. And so Bonnie's work, I think, in that way laid some of the groundwork, although there were some work before and some work after. But you made me think about, I don't want to go off on that tangent, but just what came about in this cardiac surgery studies led originally by the doctors from Japan, I think, and then happening in the US, 3 studies published in a short period of time. I'm going to think more on that idea of those that did publish that, what they went through. I know some were rejected by more high impact journals first to actually have the work published.
Hmm. Yeah, thank you.
Anyway, you two are amazing. Just the logic and the thought process, and I'm sitting here. I've had a chance to interview a lot of families, and even in this last 2 weeks, I've talked to folks that had a child in 1988, and then also in 2020, there in the Illinois area, and just the evolution of this narrative. And Natasha, you said it so eloquently of just that those were the information they had at the time, or even nowadays maybe more regional hospitals with their capacity and their technology and their staff, and trying to just make it aware. Because I think what I want to highlight real quick is just because of a variety of staffing, technology limitation. Every hospital is ran a little differently. Every hospital has some different specialties. What I hope people can hear from this interview and these sound bites that we'll make public is research and ask questions and find that there are a variety of resources, and it's growing, but it just may not be in your backyard, and it just may not be aware yet to your team of physicians. So I just appreciate just that perspective of understanding the current state we're in, which is not it's not universally known yet. So please, be patient, ask questions, research. We're going to try to make this particular podcast and these related resources available for everyone. But thank you for that. And Grace, also for your comments. You brought up the philosophy of care and decision support. We were talking before this that we wanted to highlight that. And I thought you did such a great job. But could you guys maybe explain some of maybe how you operate internally there at Lurie's of helping families come to decisions, non-judgmental. I'll leave it to that. Tell us kind of how you guys there at Lurie's operate and how you want to keep moving forward with that of informing and helping families make decisions.
Yeah, I'll maybe have Grace lead us off on that, on the sort of the prenatal counseling end and
Yeah.
what that looks like in practice, and then we'll definitely get to your question too.
Yeah, I think that it starts off by meeting a family where they are and learning about where have they looked for information, what have they already heard, and then building upon that and sharing what is known and what we might expect given their baby's unique characteristics that we may see during prenatal ultrasounds or imaging. We talk a lot about that's a static picture of an organ or a baby, but function is something different. And so we talk about what it may look like given different pathways. And we try to learn from family what values they hold and use those to guide us along the pathway. And we really do have any judgment because every pathway is acceptable. We wouldn't offer choices that we didn't feel like were good choices and that loving parents make, and loving, thoughtful parents make the best decision for them. And we try to reassure every family we meet that they will come to the right decision because there is no wrong decision when you take in all the information and you pair that with what matters most to you and your family. And it's not just about the baby, it's about the baby in the context of their family and their siblings and their community and how that looks going forward, the time it might take in the hospital or the time that might be at home. And we really think through all of those things with a family. And as they share with us their thoughts, we share information. Then we ask, what did that make you feel? How are you thinking about this? How might this change? And it's a conversation that evolves. And nobody is ever like pigeonholed into their first thought or their first decision. And so some families think, well, this all sounds really scary and I'm terrified. And I think the best way to proceed is this pathway. But as we continue to support them and learn, sometimes that changes and they start to feel more reassured. Oh, well, maybe I do want to try this more in between and see what my baby can do and what's possible for my baby because they're a unique individual. And we don't know what that looks like until they're here with us. And so I think that's how we support families in all different pathways is really providing a lot of education and then support for what they might think fits with their values best.
Yeah, I think Grace said it absolutely perfectly. It just really summarizes our philosophy, and we create it in a really multidisciplinary fashion from the beginning. So when we meet families in our fetal center, it's not just Grace and I, it's 12 people around the table. It's the maternal fetal medicine specialist, it's a geneticist, it's a cardiologist, it's a social worker, it's a neurologist sometimes. Sometimes it's a surgeon, depending on that baby's kind of fetal imaging. And we have a pre-meeting before we ever meet the family in the fetal period, where we go through all the data, we share our worries, we name all the things that are not yet known. Again, sometimes these are pregnancies at 22 weeks gestation. There's a long time left for things to go well, for things to end. There's lots of choices people might make at that gestational age. We name all those things within our group so that when we talk together to a family, we have one voice. Yes, we each bring our own perspective to the medical part, right? Like the neurologist is going to talk about risk of seizures and what to look for and when. The cardiologist is going to address when and whether we close the VSD, but it's not in a silo. Like we all say, yes, these are our hopes. If your goal is to try to have a survivor, these are our worries because let's say you have very high blood pressure already and you're only 26 weeks gestation and there's a high risk your baby might be born preterm. Options change if you have a very preterm baby with this disease who needs surgery. We may have to rethink our goals because really this is a much steeper slope to climb if you're born at 26 weeks gestation instead of term. And then we talk about the mode of delivery with an MFM right there who can now talk about C-sections and fetal monitoring in a context of those fears and worries and not just in an isolation. And as what Grace sort of alluded to, like we say choices, what we really mean is there are some families who come in and from our first questions, because we never just start talking, we ask a lot of questions. It becomes very obvious that they've already been maybe scared by the information they saw, threatened, are already really angry, don't have a lot of trust, and all they say is, my baby's a survivor. And so we don't need to talk about pregnancy termination or hospice. We're going to talk about your baby as a survivor. And we all hear it. And so we all kind of modulate our counseling based on those initial signals. And you can see people just kind of like soften because we're not going to fight. Like they're coming in this like fighting posture. We're not going to do that. As we get to know you, we're going to sound maybe some warning shots because, again, what if your baby is born at 26 weeks? What if it's a single ventricle and not a double outlet right ventricle? Like, there's going to be some like warnings along the way, but they're not with an agenda. Like, we can present hard facts while still recognizing your desire to have a baby who lives. And on the flip side of that, there are some families who come in and from some of the questions we ask, you can sense that not only are they on the fence, they're just looking for permission to not have this baby because the stuff they read is hard. Because, as Grace so beautifully said, in the context of their family, perhaps their own health, other considerations, that's just not where they can go. And so we, again, all together are there to validate that decision. We're not going to talk about 3-year-olds who have a tracheostomy because that's not what they want to hear from us. We validate a decision to either stop this pregnancy or think about a perinatal hospice approach if pregnancy interruption is not an option. and what it means to stay pregnant with less surveillance, with less interventions. Again, we validate this loving choice to not go to the NICU. And so, yes, it is all options counseling, but we don't just give a lecture on all options counseling. We spend an hour trying to understand where people might be falling. And that's just the first meeting. And then there's multiple more, because as Grace, again, beautifully said, things shift. Some people who say, yes, I want to try, but I cannot imagine having a baby on a home ventilator. Like, I'm just going to stop. We say, okay, we hear you. And also, you might be different 5 months from now. You might feel very differently about this bond, this baby. More medical data may come through to say things are actually better than predicted. It's okay to leave yourself a long rope to make a decision way later that's very different from the one you think you would make today. And again, I think you can see people just kind of like, oh, so I don't need to commit to like one bucket or the other. Like, things can truly be fluid.
So when you're working together, maybe the two of you, maybe with another colleague, your goal at that first meeting, you already have it right in your mind. If I followed you correctly, I want to know where they're coming from. I want to know where they might, maybe they haven't made up a mind where they are, but at least I know that they might already be on my baby's a survivor, that we can capture that, if we would call it a bucket, that way, versus I'm not sure I could ever envision my baby being on a ventilator. So but that's important, seems to me, as a kind of, what would we say, guideline for fetal care fetal treatment centers, fetal care centers. That's how they're called. And that initial inaugural visit, and who's at that visit, like, as opposed to randomly, well, MFM is going to go before neo or palliative care because that's who's ready to go in the room now, right? I mean, you're actually going to be established who's going to go in the room first. That's a really good way in my mind of structuring it.
I think by all of us meeting together too, as Natasha said, before we meet the patient and talking together, but hearing each other counsel our patients and understanding the concerns. What are the obstetrical concerns, the risks to mom's health? What are the concerns of the pediatricians and the subspecialists? And when we all talk together, I feel like we speak with that united voice where it can feel different when it's, as you said, John, individual counseling, one after the other. It's easier to defer things to that other group of people. Oh, they'll talk about that. When we're all together, we have to talk about it together.
Because I think the reason, and that's not just a trisomy model, that's really the Fetal Institute model at Lurie Children's. Like, the counseling is multidisciplinary from the get-go for that exact reason, to both learn from each other and hear the perspectives of your sort of counterpart consultant. But so the trisomy model just falls into that. It's just even more nuanced, right? Because the uncertainty of both the fetal period and neonatal period is very high. And again, that's that hard truth. Like, you have to say it, but there's just so many different ways to talk about this ongoing uncertainty for pregnancy or for the baby. And I think maybe that's what's lacking or lost sometimes in that smaller system, maybe counseling that's not as multidisciplinary, because there's a way to signal uncertainty that everybody's going to do differently. And the family will have this very vivid memory of one person saying, all babies die after they're born. And maybe that's not what they actually said, and maybe it is. And maybe 5 people after that didn't say it, but that's what's going to stick, which is why, again, I think there's this prickly feeling that a lot of parents very justifiably get, to be like, well, one person said all these kids die, and I saw online they don't. And we need ongoing work with the community OBs, community genetic counselors, cardiologists in small centers to say, that's just not true. And if you keep saying that, it actually sets everybody back. You're not helping the family make a decision because it's out of context. And so, yeah, just to build on this multidisciplinary counseling, that is, I think, the goal for many centers and many conditions, but it's hard to do. It's very labor intensive, it's expensive, you need a big center. But now with telemedicine and with all these other collaboratives, there is maybe a different approach as well.
So I was part of our fetal center at Primary Children's University of Utah from 2015 until I retired from actually being formally, I'm still seeing families, but in 2021. And I know that there's a network. We actually have cited the network in the books that Nick has helped produce. But it seems like with the message you're talking about now, maybe that's like already considered to be the standard approach. But the message you're giving now just seems like it's worth documenting, writing about, presenting at a meeting, whatever. I don't know. Maybe it already has been, and I'm behind the times in terms of what the models might be in fetal care centers. But I just love the way that you guys both expressed that and talked about that.
Thank you. Yeah, I'd say that is the model in major fetal centers, that counseling is truly, like transdisciplinary, not even multidisciplinary, meaning because you work together so much, you can almost know what your counterpart says and why they say it.
Right.
And I think specific to this disease, and Grace has kind of alluded to that, it promotes trust towards those other specialties, right? So if the family comes in and says, my OB keeps telling me to terminate this pregnancy, and I can't and I won't. And that's their anchor of the entire consult. They cannot move past that sort of like that goal, that somebody said something that is so hard to hear. That's not who they are. They keep saying it. That means my baby doesn't have value. That means everybody wants my baby to die. And people just can't hear anything else. And I think when you counsel with an obstetrician and you gently prompt a question like, why could pregnancy termination be a safe option? Like, what are you worried about when you keep bringing it up? And they'll say, oh, because this mom is at such high risk for A, B, and C. And she voiced in previous visits that she really is focused on having future pregnancies. I am just trying to balance the risk. And you can say, okay, like I hear the need for the balance of maternal risk, but now we all need to hear how we've already answered that question, that this mom will continue to prioritize this pregnancy and this baby. She heard the risk. We need to move on. And I think, again, when done together, like we're almost a conduit for some of that, like reverse trust building, because this woman might be pregnant again in 2 years and needs to trust her OB that they had good intentions, that they didn't just want her baby to die, that they also were focused on her. And I think that's hard. That's hard to do. And if you continue to do it in separate rooms.
That
So
perspective.
Nick, I
Yeah,
had
go ahead,
some
John.
other. Oh no, I had two other themes I wanted to bring up with Natasha and Grace, but I don't want my questions to dominate our time. Or are we okay if I ask
Yeah, if I could add
two
just
other
a
points
little.
about the brochure?
Yeah, if I could maybe
Go ahead.
add just my commentary. A lot of the conversations that I have, Natasha, you talked about, and Grace, you talked about allowing for time for families to make decisions, and the fact that when it's done in this collaborative approach, there's that longer rope, or there's that opportunity to have new information, just because time provides more information when you're in the prenatal situation, that then the choices may change, or their desires may change, their wants. And a lot of parents, when I ask them, what suggestions do you have for a future parent? What would you advise? And that was the thing, is just like, don't feel like you're trapped to make a decision on the moment. Allow for information to come, allow for feelings to settle. And so I just really appreciate that your Trisomy Collaborative group there is wanting to do this in a collaborative, multidisciplinary, holistic, all these wonderful kind of viewpoints. So that just really stuck out to me because that's what I hear parents want to tell other parents. And the fact that your care team is trying to make that a reality for them is awesome. So if parents want to give that to other parents, you guys are on the right track. So thank you for that. John, let's now ask your question.
I just want to say, what a great choice of words. Trisomy Care Collaborative. And Nick just brought it all out. But I had
Sorry,
the
everyone.
chance to read your wonderful brochure. And I had something I was going to ask you to discuss just because I think it's an important issue. And that is about hospice and palliative care. But before we do that, I wanted you both to have the opportunity to explain that difference. You bring it out in the brochure that even a parent told you that was important to make that distinction. But before I do, I have to really compliment you on two aspects of the book that I would say, well, of course, but why didn't we do it that way before? When you talked about the developmental milestones, you didn't talk about what the kids can't do. You talked about what they could do. What a brilliant way of framing that, rather than having to get something in. Like, I'm always thinking, well, I have to make sure we know that this is that developmental disability is more than Down syndrome, and these are some of the hallmarks. I love the way you did that. It was a little bit of a flashbulb moment for me. Flashbulb is also, as you know, used for when the family gets the message you were talking about earlier. The second thing that I liked in that same light, but it was maybe planned for the same reason, is that you didn't do a whole lot of talking about what the problems and complications and manifestations were. You instead went to that figure that had trisomy 13, trisomy 18, and both conditions share this in the middle. And there was a nicely worded list. I might say, by the way, that, and Nick, maybe you can help with this, the color of those bubbles, blue is a trisomy 18 color. Nick will have to remind me. I know yellow is a trisomy 13 color, but they might have green as well. You might want to change the color of your bubbles
Good
to
idea.
fit the color. Nick, what are trisomy 13 colors besides yellow? I'm not a knowing color person, but anyway,
I need to go get
we
the
don't have
book,
to
but yes, I'll send you
spend our
That's
time
those.
on that. It's something that just struck me, but
yeah.
I like the way you did both of those. And it was, I'm not sure I've seen that the information that we know we want to deliver, especially the one about the skills that one can do as opposed to what one can't do, delivered in that way. So I want to applaud you for that.
Thank you. I think that was a lot of work done by Grace and other folks who were putting this together. I think we really wanted, to your point, like if you're reaching that page and you're reading about all the challenges of this disease, we wanted a balanced way to honestly talk about the possible challenges, but not frame them all as just negative. Because I think, Grace and I talk about this all the time. Like, both things can be true at once. Yes, there are differences about how these babies develop and the many challenges with that, but they do develop and they do have skills. And that sort of graphic that you're describing, it's probably not perfect either, right? And we kind of say on the bottom, like, every kid is different. This is just a general framework that there is this sort of developmental, quote unquote, ceiling of about 12 to 15 months. But for some kids, it looks different. Some have more motor skills and less language skills. Kids with partial trisomies have all kinds of variability in that. Like, this we're very clear to say this is a fact currently we think that's supported by data. And as more kids survive with maybe earlier medical and surgical care, maybe that developmental ceiling could also shift. Like there's a lot of unknowns. Now, will it shift to the point that surviving babies with full trisomy 13 and 18 have the same language as we have? Probably not. Right? Will it shift to the point that they can play professional sports? No. But will it shift enough for parents to have ongoing hope that maybe more language or more motor skills are possible? Maybe. And I think it was important to focus on that as Grace was building that out, because what parents hear in some of that more siloed counseling is exactly what he said, the focus on all the things that will not happen. And those are so like definitive to the point that we find odd. Like, will never, right? People say, will never drink or eat or speak. And you're like, careful, careful with that. Because the second that
Careful.
baby says one word, everything else then is also not true, right? All of your predictions about complex cardiac physiology and a seizure burden, that may be true, will be viewed as untrue. So when I say both things can be true at once, you can say hard things and also have ongoing empathy that these things may mean different things to different people. Developmental potential is not always the goal of each family. There will be different complications that we need to address. And also, this kid is joyful and special, and their loss would seem just as awful and unimaginable as the loss of any other child. Like, you can hold both things at once.
Thank you.
And I think
Well said.
especially when I was thinking about presenting this information to families, I wanted to present it in a way because as medical professionals, we often talk about, a developmental ceiling of 18 months. What does that actually mean to somebody who is not a pediatrician, who doesn't know what a typical 18-month-old's development should look like? So naming some tangible things that like, these are the things kids can do at this age, and these are the things we'll expect. But also in highlighting visually some of the commonalities of the different um, trisomy 13 and 18 and some of the things that they share in common. I thought it was important to name like these are some things that we look for, and this is why, because it's related to this difference. So often when families have this mentality they have to fight for everything for their child to be recognized. They want to discount the genetic diagnosis, although we can't really do that because it really does affect each part of them. And so let's not think about them as a child with this different genetics. Let's think about them as a child with this different genetics and how we can help them to thrive. And it's not something we should discount. It's an important part of who they are as a person.
And if we find those body differences because we're looking for them based on genetics, it'll help us be better, right? We're not finding them to find fault with this baby or to convince the parents to stop. But like, it's important to know that you only have one kidney. It's important to know that there's something different about where your spinal cord is terminating. Like I think parents are often threatened by more tests because I think they worry that we're going to come to them and be like, yet another thing wrong. But like that's the focus I think has to shift. Yes, something is different. We looked for it because we know to look for it. And this is why it matters, or maybe it doesn't matter. A tethered cord, I don't know. If you also have congenital heart disease and your life expectancy is short, do we really need to worry about a tethered cord right now? Or is it just another piece of negative data that makes families feel like you don't care about my baby? And so knowing something about a condition, being an expert, looking for like physiological differences to decide whether to address them or not is all part of this equation instead of just accumulating a long, long, long problem list.
Thank you.
That's outstanding. Yeah, I'm looking at the booklet right now on my other screen, so we'll put up
I
some
think
pictures.
we lost your sound, Nick. Can't
Yeah, we
hear.
couldn't hear you for a second there, Nick.
All right, I'll be right back. I got to reset.
Nope.
Yes, we
Yes.
can.
Yes, your screen. No worries.
Yeah. Yeah, I'm going to ask Natasha and Grace to talk about something you talked about in the book in the and I think it's important for everyone to hear, and that is the distinction between hospice care, as you refer to it, as you sometimes people say, as you know, pure comfort care. You refer to it as hospice. I think you actually say
Right. Can you
newborn
guys? All
hospice,
right,
if
there we go.
if I remember the words correctly. And then the second
I think John
on
is
the other
frozen
side
now.
is intervention.
Yes.
Pardon?
Hold on, Jen. You're frozen. I think we heard the question as why did we find it important to delineate the difference
I
between
think I see you guys frozen. Maybe I'm frozen to you too.
Yeah. Let's run with that. Let's do that. I'll see if we can get John back on. But the good news is we can edit all this up.
Sounds great. So maybe, yeah,
Some
it was
technical
actually a
difficulty.
parent who was looking over this brochure who suggested that we speak to the differences between hospice and palliative care. And I thought that was very important. And I'll let Grace explain what that difference is and why it matters for this particular patient group.
Yeah, I think the reason that came up is the parent who brought this to our attention was originally cared for at a different institution after her child was born and um, met with a team who really presented hospice as an option. And while hospice is a small piece of the palliative care umbrella, in pediatrics, it's just a little piece of the pie. And so often when we're coming as the palliative care team, it's not because we want to present hospice or have the family choose hospice. And so it was important to differentiate what that means. And so hospice is really the philosophy and focus of care at the end of one's life, when we accept that end of life is approaching and our focus is not on prolonging life, but providing as much comfort and meaning to the time that is at hand. Whereas the larger umbrella of palliative care is really about partnering with families and providing an extra layer of support longitudinally to help them think through complex medical decisions to align with their family's goals and values, being a conduit of communication between family and medical team both ways to because all good relationships have good communication, so we try to be good communication partners. And then we can also focus on things that decrease quality of life, like distressing symptoms like pain or um, other modalities to just increase quality of life, is really how we differentiate those two things. Whereas palliative care is always thinking about all of those things. When we come and we know and we agree the end of life is near, then we shift and that shift of care is from more life prolonging quality to really focusing on quality at end of life and comfort.
Yeah, that is, I mean, those are definitely distinct changes. And having chatted with families with kids that lived into their teens or even in their adulthood, those are moments. And then talking to individuals that even a few weeks had gone by after birth, and then that situation arises where you need to switch. Quite wonderful. Um, I, the one thing I was looking over, I had the booklet on my other screen, so I might have been looking here to my left. I noticed just some of your like organizational routes to maintaining your Trisomy Care Collaborative there at Lurie's. It looks like you have regular meetings, or you kind of have like, when you have this family that gets diagnosed with this, I don't know if you send out the Lurie's call or the TCC call, or you have some announcement. Talk us through some of the organizational side that you're utilizing your group. And in that booklet, there is some wonderful people that are on this collaborative. Um, if you don't mind, maybe giving some inside information of how you formulated it, how you now continue to run it, some of your protocols and things. I'm curious on that side, and maybe hopefully other hospitals or other groups are listening and can borrow some good things if you're willing to share.
Yeah, absolutely. I'll get us started and then I'll definitely hand it over to Grace because she's really like the brains behind how this all
Yeah.
actually works day to day. But as I mentioned in the beginning, we have really champions from every specialty. So that is, pediatric neurology, like nutrition, cardiology, cardiothoracic surgery, general surgery, genetics, all the people listed. These are champions from those medical and surgical specialties who come to the monthly meetings where we talk about the babies who are already born. And Grace will walk us through like what questions we pose and how we do that. But we start for most of our patients on the fetal end, and that's what we describe, that perinatal counseling that's also multidisciplinary through the fetal center. It's not necessarily that all those people whose pictures you see are doing fetal counseling, because the fetal center is its own structure with its own consultants in those specialties. And so we kind of do that fetal counseling. We try to develop some birth plans and align goals between the families and all the specialties. Then the baby is born at the delivery hospital, and we tell our trisomy care partners on the pediatric end to say, this baby that we've now given you a heads up about is born. And we're going to follow the plans that we have outlined prenatally, which is that baby either stays at our delivery hospital or is moved to Lurie for subspecialty care. We put together kind of a protocol of all the like imaging and screening that needs to be done right away. And then that baby's kind of on our list. So I'll turn it over to Grace to explain what that means after that.
Yeah, I keep a patient list of all of our trisomy patients, and for those we met prenatally, they already know us, but we do have babies who are transferred from outside of our network to our neonatal intensive care unit for care, and so those families I typically meet and do more of a palliative care consult, but introduce the Trisomy Collaborative, try to answer those questions that we have, like, where did you get information? What information is it that you have? What do you worry about? What are your concerns? And we go through this. And then, as Natasha said, being part of this collaborative and all the wonderful partners. And before we started doing this, even though I've cared for babies with these genetic conditions since I was a bedside NICU nurse, I didn't realize how much screening and guidance there was for like abdominal tumors and bone health. And so our genetics partners really helped bring that data and those recommendations to light. And so now I have a dot phrase to help our neonatologists know all the things, because that was one of the things when we created the collaborative. They're just, even though we have a fairly large number of babies with these conditions that we see yearly, there's usually one in the NICU at a time, and there may be months between them, and people forget the nuances of their care, these screenings, and like who to involve and when to do things. And so I have that all mapped out. And then I create a list for our monthly review that we go over weight gain, how old they are, where they are on those screenings, what screenings they might be due for, so I can remind the primary team to order those things, or if we've talked with parents and they'd like to screen for some of those differences. We talk about how are they on their respiratory support, how's feeding going, what are the concerns. We always invite the primary team to share with us any concerns or questions they have about moving the baby's care along and progressing them. Are there things we need to talk to our ENT partners or cardiology and ask questions? And by asking questions and having everyone think during that monthly meeting, we can make recommendations to the primary team to help move the care along, to get different evaluations of the airway or thinking about different modalities of treatment, to help support the primary team, usually our NICU or our CICU partners who are caring for the baby in their unit.
Yeah, I would add to all of that exactly that point that I think supporting the primary teams is really important. Yes, our focus is always on families, but you can't support families if your subspecialty partners are not organized and are feeling distress, are in a disarray, or don't know who to talk to. Like, that's what makes families stressed. So we used to, as I gave example in the beginning, that one baby that stands out in my mind who never had an airway evaluation after 5 failed extubations. Like, that should just not happen. It doesn't happen for other kids. Like, why would it happen for a kid with trisomy? So now we turned to the ENT group and said, well, what do you think is reasonable in terms of timelines of when to do an airway evaluation? And they said, if you have congenital heart disease and you're essentially term and you failed extubation once, we're going to look right away instead of waiting for 5 attempts. And so now, within weeks, usually, if the baby is born and is term and is on positive pressure, you're going to get a bronchoscopy. And nobody on the ENT team, because there's like 10 different ENTs and PAs and nurse practitioners, no one's going to worry about it or wonder about the ethics of it or really ask any other questions other than when and safety, because their ENT champions are like, this is what we decided. We signaled it to their group. They're like, yep, the kid failed extubation. Let's look. Because again, data is helpful to then decide what to do, right? It's not that we're looking for flaws. We're saying if you have significant tracheomalacia or there's something structurally different about your airway, that may change whether we try to continuously wean you off of the vent or wean you off of CPAP. That may change when we should talk about that VSD repair, because maybe we should just keep you ventilated and grow you really well so that you can get to that repair sooner instead of keep trying to fail and extubate. And so we support the teams, as Grace mentioned, through like just decreasing all of that noise and like distress, which honestly we don't really have anymore. It's just very task oriented. And I know that sounds crazy, but like we're trying to take all the feelings out of it and say, let's get the data and decide what we're going to do based on the data.
I love that. You're making my mind race based on just experiences that I've heard. I do have a question. So you guys meet monthly. You have this kind of opportunity, Grace. My mind was kind of taking, like, you got this list of individuals we've seen, what stages they're at, and their care team. Now you guys are having this monthly opportunity to kind of be proactive instead of reactive. And that's what I'm hearing, Natasha, you guys say. We've already kind of thought through the scenarios, and we have kind of a decision tree of what we're going to go through when these decisions come up. We've already kind of mapped it out, and it removes the ancillary stress that didn't need to be there. So that's fantastic. Just like really clear, articulate. The programmatic side of my brain is just like in awe because this is a complex scenario. So I'd like to just be a fly on the wall in some of these meetings. But the thought that I was having is Dr. Carey and I had a chance to talk to Dr. Pyle, who helped write a recent, groundbreaking part of the American Academy of Pediatrics. And the thing that she talked about was bias amongst medical professionals for not necessarily seeing the lived experiences, let me say it that way, of these kids. If I'm only in the delivery room, I might not realize what's happening 3 years down the road. And so my perspective, I might have a bias or my feelings. It seems to me that the Trisomy Care Collaborative with you guys meeting is going to change that. Like, information is going to be filtered back. Maybe even patients that come in, they get a chance to see them down the road, whether it be weeks, months, years even, right? Is that something on the radar of your guys' discussion of like these lived experiences, the human impact of it, kind of like filtering back into your TCC, the group here, the collaborative?
I guess I always think about the family's lived experience, and that's what drives me forward. So I probably talk about it a lot. I don't know if I've ever thought about it as an intentional thing that I do or bring to our group.
I think you do, Grace. I think by just allowing people to continue on this journey with good care, and again, like, we are flawed, right? Like, we are highlighting this perfect system in theory. It breaks down. There's I wouldn't actually say conflicts anymore. We really have not had major conflicts, not within the group, not with parents in years, really. But, things get forgotten. We're not as perfect as we can be. Parents continue to struggle. It's not always perfect. But I think the lived experience of the families, to your question, Nick, it does percolate through the teams, right? So the ENT resident who may have read in a textbook that all babies with this condition die, or all in like a persistent vegetative state, or all have a terrible quality of life, whatever that language means. They read that. And then they're on an ENT service that participates in multidisciplinary counseling around tracheostomy, hears the family's perspective, doesn't sense any tension from anybody else about it, then sees that kid go through surgery, recover pretty well, just like anybody else, then go to a home vent and then leave, and they do Bronx outpatient. I bet that ENT resident's perspective is now different. And what they may tell their peers, or when they get a job at a different institution, when someone says to them, all these kids died, he may say, that's weird and not true. And again, there is a skill in doing that without conflict. So I do think that lived experience percolates through multiple team members, and people don't learn through lectures. They don't. They learn through their own experience. And so if our cardiac ICU, who used to be quite skeptical about these kids because they are hard and their morbidity after cardiac repair is different than a baby without trisomy, and their length of stay is super long. When we first came to them and said, like, heads up, we might be getting more of these patients, it's not like they were like, oh, thank God, let's do more. They were like, oh, this is going to be brutal. But now, because there's a system in place that, again, diminishes that value noise and ethics noise, and they can just focus on like safety of the cath, timing of VSD, making sure that kid is a survivor after surgery, trach or not, like it just makes them feel more maybe successful. And your own success clouds how you feel about a patient population. If all you've seen in the past that they all die, yeah, you're going to feel like this is futile care. Again, I hate that word, but that's what people say. But if your experience is now that some kids survive and go home, and even if they don't, even if they die, but there's this sense of partnership and trust and closure on behalf of the family because they saw you really try and not like fake try, that also feels good. And so then people want to do it more and maybe want to teach about it more and want to talk about it more and become champions for it even. And so I do think the lived experience of families definitely changes how the clinicians feel. And we see that, and Grace does a lot of this. We provide a lot of like second opinions to other institutions. Not a lot, but like we've done a few over the years now, and I think more are coming for kids who are never actually going to come to Lurie. They live far away. But then when we generate that multidisciplinary second opinion letter of all the things we would consider here, a lot of those parents ended up staying where they were, and those teams did the things we suggested they do, even though they previously said no. And so that's a lived experience of a family who asked for a different approach, who got it, who then perhaps influenced what is available at that center. And if that kid is now a survivor and is less agitated because they're actually like appropriately supported and ventilated, maybe those teams are not going to say this is a terrible survivor. Maybe they will change their mind.
You two are amazing. And Grace, the fact that you kind of, it's a focus of yours, and it just, I really, really am appreciative of these comments. I can't tell you enough, as someone that hears the other side, just you're aware of the barriers you're trying to remove or reduce, right? These are important decisions to make. These are complex care children, and it's like you said, it's something that's going to evolve. And so anyway, I just really appreciate the approach that Lurie's is taking and that your Trisomy Care Collaborative is taking. We're excited that we'll link to it. I know we've referenced the booklet. There'll be a link and directing them back to your guys' web pages and other things there. So fantastic. John, have we missed anything? Is there any questions burning in your mind that we just need to ask these two?
No, I just want to summarize the importance and quote both of you. Again, that two themes that just emerged from this part of the conversation: system in place and lived experience. So just those ideas are so good and beautiful on their own, but then to hear them, then I think I agree with you, Natasha, even though I'm seeing it at Primary Children's in Utah as well. The system in place, we talked about data earlier, but the system in place actually helps the evolving attitudes.
Mm-hmm. Yeah, I think
Moves along
diminishing
the
the
evolving.
burden of the work helps the work be better. It helps the parents feel better. But if you're constantly burdened by the logistics of it, by the miscommunication, by the conflict, it's just not going to be as good. And I think parents, they sense that. They sense that someone is not kind of rallying for their baby, or other people have doubts. And, we're all the products of our own sort of little, like ecosystems. You might feel super committed to something, but you start hearing stuff in your ear to be like, I don't know, is this right? Is this good? And people turn, we're all sort of complicated in this. We're not perfect. And so having a structure that constantly supports that narrative is helpful. So thank you for recognizing that.
I, where you guys are making quite the strides of moving the advancement forward, and I'm grateful across the board that the medical. We're in. John and I had a chance to visit the Orlando community and the Orlando Health group, and they're building hospitals that are more collaborative, a pediatric hospital where they can receive care in one place, so they don't have to go to satellite locations. Like just this evolution of collaborative, multidisciplinary. It's really, I think it's going to help the care, but in particular for our kids, because they are complex and the scenarios are layered. What a wonderful opportunity, because just some of your scenarios when we operate in silos, this doctor, the OB you referenced earlier, is very concerned about his patient, and he's going to give advice to make sure that the things he can advise on. But if you can get that holistic multidisciplinary approach, then all of those concerns can be, it becomes a true answer or a true suggestion. What I'm at awe. I'm so grateful for this conversation. And I'm excited that more of these processes and protocols can be filtered throughout the nation. That would be wonderful. Grace and Natasha, do you want to just kind of briefly tell, like, maybe the immediate next steps that you're hoping with the your Trisomy Care Collaborative there at Lurie's? Any sort of outlook, any sort of progress? Just, it's 2026, but when we're recording this, do you guys want to give us a little snippet of what maybe be coming down the line this year, or just some last words of advice that we could have the listeners hear from you guys?
Go ahead, Grace.
I think that maintaining what we've built is kind of my goal. Getting the webpage off the ground, because in talking with some of our parent partners, learning that there's just not a local resource for them to connect with and feel grounded. And this is why I love this work, because it's not something that would have come first to my mind. But in hearing that from one of our moms, it was like, oh, wow. Like, we need to put something up here, because part of what I want is for people to not feel alone, no matter what pathway they choose, which decision is right for them. I think that is a scary place to be, when you feel all alone and you're looking for answers. So I hope
Yeah.
that we can continue to be that resource and support families in their journey.
Yeah, I agree, Grace. I think for the practical part of it, like, we're translating this resource into Spanish. There could be maybe other languages that we might think about, because especially for our parents whose primary language is not English, that's a whole other silo that they have to navigate, and that's really difficult. So we're hoping to help with that. I'd say another thing that we keep thinking like who else should be part of this group and like where the current gaps are. I'd say the pediatric ICU is an interesting, currently non-partner, but I think is becoming a partner. Like as more and more babies survive, because our initial focus was very perinatal, neonatal. That's who we are. That's where the original touch point is into this disease, right? These are usually fetal diagnoses. These kids are usually in the NICU. So we focused on that. But now there is a large surviving cohort of kids who are 1 and 2 and 5 who have complicated medical technology, who have ongoing sort of healthcare needs that bring them back into the hospital. And a lot of the time, the pediatric ICU becomes their home. And so we're thinking of really establishing a better partnership, again, finding a champion in the PICU who kind of like understands the beginning of this disease. What has this family been through? What is the data about outcomes? Because PICU is hard. Their priorities are different as an ICU. They need to get you in, they need to get you out. There's a national shortage of pediatric ICU beds. It's so they have very different lens. And if the kids are repeatedly in the PICU, there's this narrative that forms like, well, what's next? And so again, we want to help our PICU partners understand how much is still unknown about this disease, different types of trajectories, different outcomes. So I'd say that's one focus. And that I think gets into like, will we one day be able to have these resources for kids who are 6 and 7 years old? Like that means pediatric GI and pediatric neurologist who doesn't just focus on the neonatal seizures, but who focuses on later like neurologic outcomes, help from our like developmental clinic partners, which currently we don't really have because again, the focus is narrow. It's in the beginning of life. But I'd say if you ask like, what are we going to do in 5 years? It's probably really build it out into the more like sort of like the general pediatric space, because let's be honest, general pediatricians are not equipped. And I don't mean that as a knowledge gap. It's just intense to coordinate 10 subspecialties, read up on the literature, support the family. And so there really needs to be this more long-term system. So that's hopefully a place we can start filling. It's harder to do. And then something else that Grace and I are chatting about is this peer-to-peer support that's Lurie focused for families, because we now do have a group that's been through the program locally that had a range of experiences. Again, everything from pregnancy interruption to perinatal hospice to fetal loss to neonatal interventions to a neonatal death to a baby who survived who's now 4. Like we have multiple parents in these categories who I think are looking to give back, to understand that peer support is important. But how do you know they're ready? How do you train them to be truly neutral, which I know is a difficult word because everybody brings their experience, but like, how do you support a family who's still, for example, undecided when you had a very particular experience? Like, how do you do that? And so we're thinking together with some of the other partners, like how to support parents in becoming a peer support parent.
Yes, that one hits close to home. We love that one. I think just the overarching feeling that I have, when Grace, you said it, is providing hope. Just you said it earlier, there are typically, just numbers wise, there may be one child in the NICU with one of these conditions, and there might be weeks or months apart before the next one. Just sheer volume of the statistics of these two conditions lend this to be somewhat isolating. And even in a hospital the size of Lurie's, you like are the only one in the hospital. You already feel kind of like, okay, I'm unique, I'm special, but that also provides a loneliness aspect to it. So I appreciate that you're looking at the peer-to-peer. We are at Soft. I mean, that's what we were built on, is just parents getting together and just being around each other, maybe shared experience, giving advice, hugs, right? Just some sort of comfort. And so what a great kind of effort that you guys are providing to create an environment, one, where you have this multidisciplinary approach of a team, and then two, that it creates an environment that we've thought about you. You are not alone. We've helped other families, and that creates its own psychological benefit as well, just from that fact that you've taken the time leading up well before the next child is born, that you guys have did doing a lot of work preparing to help that child and that family. I mean, I think it's just really meaningful because it is isolating. I know for myself, having I live in a large metropolitan area of Phoenix, and I don't know, as growing up, another family within, the whole city of Mesa that had trisomy 18, another sibling. So these families start to somewhat feel isolated. And so the fact that you're doing the opposite, you're surrounding them with support, you're providing resources, it's just, I think, going to mean so much. So keep working towards, just ever expanding that program, and to think about, yes, the adolescent years, the teenage years, the toddler years, and having all that holistically approached is going to be awesome. So that will be a good endeavor to take on. We could keep going on, but you two have to see patients and you have to go do things. Does anybody have any last words? I don't want to be the one to say the last words, because I just feel, I don't know, I'm just very impressed and very excited for the future. John, Grace, Natasha, would any of you like to kind of say some lasting words or some thoughts or advice for others?
Just thanks to both of you for this really insightful and impactful conversation. And Nick, thank you for, again, leading, I think, what we could call a great conversation.
Yeah, I would agree. I don't think the last words should be ours. To my comment earlier that we're standing on the shoulders of giants, I think John Carey is certainly one of those giants. And, um, building on that work and just kind of recognizing the uniqueness of this disease, and also not that it's just like any other complex condition, is a very well taken point by John Carey.
Well said. And yes, John, the most humble man. Yes, Dr. Carey, you have led us so many to this point. At the heart of it, it's looking out for other children. It's helping them. And so, again, thank you so much. What a wonderful podcast. For those listening, this is Talking Trisomy, where all we do, just like for the last hour and a half or however many minutes this edits down to, we've been talking about trisomy. And Natasha and Grace, you guys, your work, we appreciate it. Thank you for moving the trisomy care forward. We've talked about supporting families. We also, another mission of SOFT is to change the narrative. And Natasha, I think you are right. It is changing. And the more people that can be aware of the kids that live and the kids that overcome this and the kids that defy the odds per se, and that data is proving that the narrative is changing. If we can all just wrap our minds and be excited about that, more families and more children will be provided the options that are best for them. And so thank you so much for that. Again, Talking Trisomy, if you've liked this, please, share it, repost it. We'd like this to spread throughout. We'll have a lot of information that will link back to the Lurie Children's Trisomy Care Collaborative. What wonderful resources you have. And I know you're going to get more up, so we'll just link to the website when it's ready, Grace, and anything like that. But thank you for all you're doing. And until next time, again, thank you, John. Thank you, Natasha. Thank you, Grace.